So the first question is, a 3-year-old boy is brought to the provider by his parents because they are concerned about his behavior. He has poor social and language development. He only knows 7 to 8 words, communicates by pointing, and does not use two-word combinations. He also does not socialize with his peers and only plays by himself. Another concern for the parents is that the child does not maintain eye contact. So, what is the most appropriate next step for the evaluation of this patient? Childhood autism spectrum test, MRI, EEG, hearing test. So, what is the opinion about this question? So, okay. Now, participants have started giving the options. Any more? Any more? We'll keep around 1 to 1.5 minutes on every case, and then accordingly we'll proceed. Okay, so some of them are mentioning A, some of them are mentioning B, and some of them are mentioning D. So, any other options, any other thoughts? Because I'm getting all the options except C. So, let's go into the detail of this question again. So, here is a 3-year-old child who is brought by his parents, and he complains that they are concerned about his behavior mainly. So, the behavior, what is said is that he has poor social language development. So he only knows around 7 to 8 words. So definitely the vocabulary of this child is very poor. But one good thing they have mentioned, he communicates by pointing. And that's a very good positive sign. And does not use two-word communication. He uses only one word because his vocabulary is poor. So he does not socialize with his peers and only plays by himself. And the child does not maintain eye contact. So overall, it appears that yes, there are some features which are suggestive of poor socialization skills, poor eye contact, and poor language development. Now, as per this, it appears to be straightly that the child might be having autism spectrum disorder. But we are not sure with this because the reason is, again, the child communicates by pointing. And more or less, whatever is being described here is more of his problem is related to his language development. And probably he is not able to socialize with his peers and play himself, but probably because he might not be able to understand or he might not be able to perceive what is being said. Or I would say here, what is being said is he has a poor receptive and expressive speech. So in this case, though it appears to be, please kindly mute yourself. Though it appears to be at first go that the child might be on autism spectrum disorder, we are not sure. But still, we cannot jump directly on a conclusion that the child is having an autism spectrum disorder. Any child which is brought to us with complaints of hearing, language issues, not able to mingle, the first and foremost thing we need to rule out is hearing test. Hearing is the first and foremost step which is required. Definitely, other tests are also important, as you have mentioned, childhood autism spectrum test. Now, childhood autism spectrum test is not a confirmatory test; it is a screening test, like MCHAT. But here in India, we generally don't use; we use it as an MCHAT. But MCHAT, childhood autism screening test, these are screening tests. So here, as and one important feature here, which is communicates, he communicates by pointing. Now, pointing is a very important indicator or a very good point hallmark, because majority of the times if the child is on the autism spectrum disorder, pointing is one of the most important early signs or red flag signs, which here the child is not being mentioned. Eye contact could also be a reason because he is not able to understand what is being told to him. So definitely he might not be able to maintain a good eye contact, in the sense because he might not be able to understand what is being told. So the first and foremost thing in this question is to rule out hearing test. Now, provided if this hearing test option would have not been given here, there would have been some other option, then probably we might go for the childhood autism spectrum test as a screening. This is also not a confirmatory test, it's a screening test like in child. So here the best available option here is that how we have to evaluate in this scenario is option is D. We should go for a Bera hearing test in this child. Okay, so I hope I'm clear with this description and explanation for this question. So let's go on to the next question. All of the following are classified under neurodevelopmental disorders as per DSM-5, except autism spectrum disorder, specific learning disorder, intellectual disability, communication disorders, motor disorders, speech language disorder. So, which of the following is not being classified as a neurodevelopmental disorder as per DSM-5? Please remember, I am not talking about DSM-4, I am talking about DSM-5. So anybody wants to give it a try, or anybody wants to give a guess, or anybody knows they are very much sure? Okay. So most of them have answered the correct option. Sorry. So I'm getting most of the options I'm getting as E. Most of the options I'm getting as E. Any other wants to give, or everybody wants to go with option E? Okay. So speech language disorder is the right answer. Speech language disorder is not considered to be as a neurodevelopmental disorder under DSM-5. Okay, so other than speech language disorder, all others, autism spectrum disorder, specific learning disorder, intellectual disability, communication disorders, and motor disorders are considered as a neurodevelopmental disorders and are classified under neurodevelopmental disorder as per DSM-5. Now, to make this question more complex, I could have added one more option as sensory motor disorders. Instead of motor disorders, I would have added sensory motor disorders, and then I would have opted which one of the following is not considered. So only these are the first five are considered as a classification under neurodevelopmental disorders. Only motor disorders are considered as neurodevelopmental disorders. No sensory motor are not considered. It is exclusively motor. So in this, the right answer is speech language because all the other five are classified as neurodevelopmental disorders under DSM-5. So most of them have answered E, motor disorders. So that is not the right option. Okay. All of the following are considered under DSM-5 as anxiety disorders, except now these I have specifically taken because they are all related to pediatric population. So selective mutism, agoraphobia, separation anxiety, anxiety attachment, and these are all DSM-5 anxiety disorders. So any one of them, or it is all the above. I have not mentioned the options A, B, C, D, E. So it is either E or any one of the above, which you feel. Anybody can give it a try. Let's give it a try. Okay. One have given an answer. As per person, all of them are classified as anxiety disorders. Okay. So here let's discuss selective mutism. We know that where the child goes specifically undergoes mutism where he will not talk, not speak at all. That may be because of an anxieties or XYZ reasons. So it is considered as anxiety disorder under DSM-5. Agoraphobia, we know that there is a fear that he might go something wrong in a particular environment. He might not able to get escape. So that is also considered as an anxiety disorder. Separation anxiety is a very common thing which we know which comes in a typical age group of toddlers or less than that. And where the separation anxiety even more in neurodevelopmental disorders, children having autism or ADHD, where the separation anxiety will go beyond a particular age group, which is considered to be a normal in particular age. Anxious attachment is nothing considered as a neuro is not considered to be as an anxiety disorder under DSM-5. So all the above three are considered, and the one which is not considered is anxious attachment. Anxious attachment, there is no such term under DSM-5. These are only selective mutism, agoraphobia, and separation anxiety. So the correct answer here is anxious attachment. This is the one which is not considered as anxiety disorder under DSM-5. Okay, let's go on to this question. A 20-month-old girl presents for a surgical consultation. Her physical examination reveals mid-face hypoplasia, craniosynostoses, and anomalies in the hands and feet. What genetic error is the cause of these findings? So it's little probably it's a little difficult, I feel. Yes. So the correct answer is B because it could be an upward or it could be Cousin syndrome, where typically the features present with mid hypoplasia, craniosynostosis, and anomalies of hands and feet. So the right answer is B, that is FGFR2. These are the genes which are involved in this syndrome associated with craniosynostosis and hypoplasia, that is Cousin or Perth syndrome. Yes, the answer is B. Most of them have marked it correctly. Okay, let's go on to the next question. A 5-year-old boy presents with concerns about his performance at school. He takes much more time than other pupils to learn and is very socially isolated. On physical examination, the boy has a narrow face and protruding ears. If the boy is presently diagnosed with Fragile X syndrome, which type of behavioral issue is most likely to be seen? So they have given the clinical presentation of this child. They have told it is presumably diagnosed to be as a Fragile X syndrome. So what type of behavioral issue you will see in this child? Becoming overwhelmed easily by stimuli, aggression towards people and animals, selective mutism, coprolalia. Okay, okay. I'm getting multiple options. So I'm getting the various options. Any other participant, any other delegate want to give his opinion on this? Okay, now we know that Fragile X is one of the most common syndrome which is associated with children on autism spectrum disorder. Okay, so he takes, so probably they are concerning about the Fragile X, and the Fragile X is the most common association either with an ADHD or with an autism spectrum disorder. Now, the most common problem with children on autism, Fragile X, associated being, as they have mentioned, other peoples and learns very socially isolated. That is, they have socialization issues. So, the probably the most common is because they get overwhelmed by the sensory stimuli. They have emotional dysregulations. So, aggression towards people and animals is not the option, because aggression towards people, we might think at one, but that aggression is not always. We know that children on spectrum or maybe on ADHD, they don't have aggression always. The aggression only comes in a situation dependent. So that means to say they are not emotionally, there is a dysregulation of emotions in them. They are not able to regulate their emotions. So in other ways, they get overwhelmed by the stimuli, the sensory stimuli, or by the environmental stimuli very easily. So the correct option, or the most appropriate option for this question, is option A, that is, they're becoming overwhelmed easily by the environmental stimuli. So rather than B, it is more favorable to go for option A. Do you all agree with this option? Now, what is this coprolalia? Coprolalia means what? Now, coprolalia is something where there is an outburst or absence use of language or words. And it is considered to be, other references might be when there is a sexual attack or any other thing. So it is basically, copromelia means it's an outburst, involuntary outburst of abusive language or some derogatory comments. So that is not at all related with this autism spectrum disorders. So the and selective mutism, we also know selective mutism where the child undergoes mute. It is more of a anxiety disorder rather than coming under this autism or ADHD. So the most appropriate option is option A. Now, a question on Eric's stages of psychosocial development in humans. Now, Erickson's stages of psychosocial development in humans is influenced by all of the following except sexual, social, biological, and psychosocial. Now, Erickson's stages of psychosocial development, Erickson was a person, he had given a concept of psychosocial development in humans, and there are approximately around 8 to 9 stages of development on psychosocial and psychological awareness of humans. There are around 8 to 9 stages starting right from the infancy, from the birth till the adult age up to 45 to 60 years, where they have given different stages like gratification. There are 8 to 9 stages are there, maybe gratifications, acceptance, and compliance. So misgratifications, and they are all different stages. I can't tell the all stages, but this is how he has classified these stages of psychosocial development in humans. So all these stages, 8 to 9 stages of psychosocial development in humans, are influenced by all of the following, except. So all those 8 to 9 stages, they take into consideration all these parameters except the one which is mentioned here. So which is that? Is it sexual? Is it social? It is biological? It is psychosocial, psychological. See, biological, one of them have mentioned biological. Biological, it cannot be there because, as I mentioned, it is divided according to the ages. So, biological, that means it's coming, taken into consideration the biological factors also, because he has classified according to the different ages or depending upon the age of the person. So, the correct option here is sexual. It doesn't include this sexual desires and sexual influences. Other than that, it includes all the other factors when he is describing all the stages of psychosocial development. So, psychosocial development itself means it is taken into consideration the psychological factors. Social, it takes into the social factors. So, the doubt is only about the two, sexual and biological. So, it doesn't take into the sexual component, whereas it takes all the other stages, social, psychological, and biological. So it's a complete stage. It describes very nicely the all 8 9 stages of psychosocial development, starting right from the infant. So the correct option is here is sexual. That is option A. I think this is a repeat question. So a 7-year-old male child with no significant developmental history, had recently shifted to a new place with parents. The mother discusses the problem with doctor, mentioning his son has shown sudden loss of speech, language over the few months. He doesn't respond to name or any other instruction. We have also noticed a change in his behavior. He gets agitated and aggressive nowadays without any unknown reasons. When we try to ask him, he does not speak anything. Mother also notices some twitching movements of hands, mouth, and during sleep. He is often gets awake in the middle of night. We are worried as we feel he might be missing his school friends. Doctor advises sleep EG, which shows bilateral paroxysmal sleep activated paroxysms predominating over the temporal and temporoparietal regions with generalized sharp and slow wave discharges. So a typical EG finding has been mentioned. What is the best initial approach in this case? Refer to SLP, trial of risperidone, trial of steroids, or trial of methylphenidate. So here there is a 7-year-old child. There was no significant developmental history, but they have mentioned that there is a sudden loss of speech and language in this child, and otherwise, and it does not start and it doesn't respond to name and instructions. There is a change in his behavior. There is a change in his sleeping pattern. There are some twitching movements, and EG gives you a typical pattern of temporal and temporoparietal region with sharp wave and slow wave discharges. So this is most likely to be a, as yes, some of them have given the options also. Yes, option C is the right option, trial of steroids, because the best initial approach. So the best initial approach in this child would be a trial of steroid because it's most likely to be a case of Landau-Kleffner syndrome, LKS. So it is a most important differential diagnosis in a child on autism spectrum which having sleep issues. So here there was no previous history. There was no previous history. The child was absolutely normal. And the typical age of presentation is typically around 5 to 10 years of age of LKS. And the EG finding which are giving here also correlates typically with the findings of LKS. No doubt, other supportive treatments like speech language for the speech behavioral issues or attention focus issues, we might need to give a trial of methylphenidate, or when there is an aggressive behavior to control the behaviors, self-injurious, we might give a trial of risperidone depending upon the situation. But the initial first approach in this child would be a trial of steroid, taking into consideration the possible diagnosis of LKS. So a number of psychotherapy approaches for ADHD demonstrate evidence-based effectiveness. Which one of the following have shown the best chance of success? I think it's very simple. Behavioral management, social skill training, other approaches, example, alternative treatments, or all the above. Yes, the correct option is A, that is a behavioral management. Now, to make this question, if we want to make this question more complicated, when we come into the categorization of the age, when we mention the chance age, like if the child is more than 6 years or less than 6 years, there the approach and evidence-based practices differs a bit. I'll discuss you in the future slides on I have given some questions related to ADHD with respect to the age of the child. In that case, behavioral management plus the medical, that is the medications, they have an evidence of level 1 or level 2 depending upon the age of the child. So here, if we talk broadly, then yes, in these options, in the given options, behavioral management is the most evidence-based evidence-based practice which is found to be effective for management of ADHD. Social skill training, yes, it has to be given. It is a part which we generally try, but the most effective is behavioral management. So, okay. So a 13-year-old boy presents to the clinic for evaluation of speech. The speech pathologist assessed this patient's didokinetic rate. During the assessment, she notices that this patient is making inconsistent errors and every time changes the sequence of time sounds. Which of the following is most commonly underlying reason for his symptoms? Dysarthria, apraxia, aphasia, ataxia. Now, what is this didokinetic rate? Now, didokinetic rate is basically it's a method which is used by speech language pathologists or speech therapists to check the motor, what we call motor speech rate. What they do, they basically give you a multiple counts in repetitions. For example, open your mouth, up, down, move your tongue in and out. So these means diadokinetic rate, where they are giving you the sequence of activities to check and evaluate your sensory, to check and evaluate your speech motor part. So here they give you a set of sounds, or they give you a set of activities sequences where you have to repeat continuously. Where okay, I think there was a network issue. Am I audible? I hope I am audible to everyone. Okay. So in this case, so that means to say what I was explaining about what is this diadokinetic rate. So diadokinetic rate is for the evaluation of your speech motor parts. So among them, which of the following is the most likely reason for the underlying reason? So here the speech language pathologist was giving him a sequence of sounds, and every time wherever he changes the sequence of sound, there was a problem, and there were consistent errors in repetition of sounds. So what is the most likely cause for this child? Okay. Here, most of them has given me the option as A. Here, the correct answer is apraxia. Now, apraxia is a typical component where the motor speech component is affected. And diadokinetic rate is a typical test which is being done by speech language pathologists to rule out apraxia. Dysarthria is basically a articulation issue where they will not be have any problem where they change the sequence of sounds. Here the child is making a problem when he repeat changes the sequence of the sounds. So this typical word diadokinetic rate typically happens in a person who is having apraxia of speech. Now, what is apraxia of speech? Basically, apraxia of speech is something, although SLP will be the best person to explain on this. But if I tell you the difference between apraxia and dysarthria, dysarthria is basically a problem in articulation. It might be phonological or it might be an articulation issue. Whereas if we talk about apraxia, apraxia is more of a problem. Sorry, dysarthria is more of an articulation issue, whereas apraxia is more of a problem where the child, where there is a mismatch combination between the motor and the sensory motor problem is there. The child is not able to, sorry, motor verbal problem. The child is not able to express the correct sound which is being said, though he is able to recall from the brain, but he is not able to produce that sound exactly. So that is why every time when the SLP is making changes in the sequence of sounds, the child is not able to catch up with the sounds. For example, he might say ma, ta, pa. He might get confused and say instead of ta, pa. Whereas dysarthria is articulation, where he might be able to recognize the sounds correctly, but when it comes to the pronunciation of a word, then it might be a problem in related to that. So here dysdiadokinetic rate is a specific thing and a specific rate which is being judged in a person who is having apraxia of speech. So here the correct option is B, that is apraxia. Whereas aphasia is something which is related to the central nervous system, that is a brain related. So here the most common changes which we'll see in the MRI findings will be related to the temporal and parietal lobe. So it can be sensory or motor aphasia. We know that Wernicke's and Kaysen. So it will be more of a neurological rather than related to a speech part or a language part. And ataxia is again as a neurological. So it is more, the correct option here is apraxia rather than going for dysarthria in this. Now, among the following early intervention strategies for ASD, which one of the following is not child-centered approach? Okay, so which one of the following you consider think that this which one of the following is not a child-centered approach? Pivotal response training, naturalistic training, discrete trial training, or none? Is not child-centered approach. Child-centered approach is where we are not being where these are all early intervention strategies for ASD, and these are all evidence-based. So child-centered approach, which one of the following is not child-centered approach, means where we are not doing things as per the interest of the child. We are doing things or we are making the child to do things as per the interest and as per the guidance of the therapist. So it is more of a therapist approach. We need which one among the following is a child-centered approach? Okay, so the correct option here is pivotal response training, PRT. Now, pivotal response training is one of the early intervention strategies which we use for an ASD children, and it is being used more by play therapists where the approach is more towards the child centered. For example, suppose there is a child and he does a lot of stimming, he keeps on rotating the red wheels. The therapist comes and tell, okay, pick up this blue car. He is obsessed with the red car. The therapist come, pick up this blue car and let's play. He again goes to the red car. He again picks up the red car and keeps on rotating. The therapist comes, no, remove this. We will play with the blue car. We'll play with it, but he wants that red car. So what here the therapist is doing? The therapist is not doing the child-centered approach. It is more of a therapist-centered approach because he wants the child to play with the blue car, and he's insisting him to play with the blue, but the child wants to play with the red card. So now let's go with another play therapist. Another play therapist comes and jumps in between and tells, now let's do a pivotal response training, which is a child-centered approach. So what does this second play therapist does? He sees and observes the child, and he sees that the child is continuously obsessed with the red car and keeps on rotating the red wheels. So what does he do? He he brings up another red car with him. The therapist gets a red car and he keeps on rotating the red wheels along with the child. So the child gets fascinated. Oh, this is something which I'm doing, and the therapist is also doing. So he gets little motivation. Oh, that's something he's doing great. I'm doing something great. So he gets someone is doing that. So what does the therapist is doing? The therapist is observing the child and doing it as per his interest. Now, therapist again gets one red car and keeps on rotating, and he sees that the child that therapist has brought the red car, he again pick up the red car and keeps on rotating because he's doing something, the therapist is doing something which is motivating the child, and child motivation is with that continuous stimming or rotating. Now the therapist gets some white car and keeps on rotating. So because he's observing, he's fascinated. Probably after a period of 3 to 4 times, the child will get the white car and keep on rotating. So now what does here the therapist done? He has used the child's interest in diverting his attention from red color to the white. So this is what we know as child-centered approach, and this is a typical example of which we do in a pivotal response training. So as a result, among them, all of the following is not child-centered approach. The one which is there is answer is uh, pivotal response training is a child-centered approach. Similarly, naturalist training is a child-centered approach. But here, which one is not is a discrete trial training. So discrete trial training is a not child-centered approach. Discrete trial training is a method of teaching the instructions to a child on spectrum. And I think we had discussed initially also discrete trial training. There are different steps are there. First, we have to take an eye contact. Suppose you are giving some instruction to the child. Go to the kitchen. He doesn't look at you. Again, you give a command. Go to the kitchen. He doesn't look at you again. So this keeps on repeating. So discrete trial training is a method of breaking up a sentence into smaller parts so that the child is able to follow and do the instructions. So bring down, go to the kitchen can be broken into multiple steps. That is a part of discrete trial training. What is the first step? Take the eye contact. Once the child gives you an eye contact, give the command, go to the kitchen, and then wait for 15 seconds for the child to process. You don't have to repeat immediately. He doesn't go to the kitchen, go to the kitchen. No, wait for the 15 seconds. And then if it doesn't respond, you again repeat the command with a prompt. You don't have to repeat the command because you have given it once and the child has given you an eye contact. The first important component is taking the eye contact, giving the command, waiting for 15 seconds. If it doesn't respond, give a prompt, go to the kitchen. It can be a visual prompt, it can be a verbal prompt, or it can be a physical prompt. That is, you are taking his hand and leaning towards the kitchen. And once he completes the task of reaching the kitchen, you reward him either in the form of clapping or applause or whatever. So these are the different steps of discrete trial training. So it is not a child-centered approach. It is an instruction giving training which is being given to the children on ASD. So it is one of the early intervention strategies where we deal with ASD. So the correct option here is DTT, discrete trial training. So now coming to the next question. A 4-year-old male child with features of autism not showing any eye contact, poor response to call name and delayed speech, and poor imitation skills. The child is on various therapies. The therapist advised the parents to get disability certificate as this will benefit the child in long term. The child was assessed by a multidisciplinary team comprising pediatrician, clinical psychology, and psychiatrist. The score of ISA, that is Indian Scale of Autism, who came out to be 85, IQ was 87. The disability certificate will be issued with the following: mild autism with 40% disability, mild autism 50%, moderate autism 40%, or child is not eligible for disability certificate. So what is the correct option here? Okay, some parents and some participants have mentioned option B. Any other? Okay, let's discuss on this. So the score is 85 and the IQ is 87. See, this is the norms of ESA score, ESA and degree of autism for less than 70 normal, 70 to 106 mild, 107 moderate, and more than 53 severe. So this is a classification. Now, as per is the score is 87. So 87, the 85. So 85 comes into the category of mild autism. Now, one thing is clear, the child is mild autism. Now, what is the percentage of disability? Now they have, the ESA has also classified the disability of the child as per the score of ESA. So for 70 score, the percentage of disability is 40. For 71 to 88, the percentage disability is 50. For 89 to 105, it is off. So the child comes in a score of 71 to 88. So 71 to 88 means it is coming under 50% disability. So that means the answer would be mild autism with 50% disability. But this is not the right option. The reason being, in India, as per the government norms and as per the next year, as per the addendum which came in year 2021, they have given the classification and guidelines have been given to DDGHS and all the government hospitals that for the autism disability certificate, the child should be 6 and more than 6 years. For the dyslexia disability certificate, the child should be 7 and above. And for intellectual impairment or other, there is another age criteria. So I will share you that article. It has came in the year 2021 where they have clearly mentioned. So here the child is not eligible for the disability certificate because he has not reached the age of 6. So a child, unless and until he has not reached the age of 6, the certificate of disability in relation to autism will not be issued in India. So this is very, very important. Another important thing is disability certificate will be issued after every 5 years. So that means till the child is not reached up to the age of 18 years, they will be mentioning as temporary disability. So you might be thinking that autism is not a temporary disability, but why they have mentioned temporary? Because it has to be renewed. So this temporary disability is being mentioned in terms of renewability. So up till at 5 years, it will be issued at 6 years, then it will be at 18, 10 years, and then again at 18 years. So at 18 years, it will be mentioned at permanent disability because then it not is required to renew. But till then, it has to be renewed. That is why the disability certificate will be mentioning as temporary disability. And it will be mentioned, it will be released only once the child is reaching the age of 6 years. So this is very, very important that the child should be at the age of 6 years. So here the answer is D, though the option mild autism 50% disability is absolutely right, but the child is not reached the age of 6 years, so that the child is not eligible for disability certificate as per the government of India. So I will share you that article also, but just for your knowledge, in 2021 or 22, that addendum came where they have given the clear-cut classification for intellectual impairment, for dyslexia, specific learning disability, for autism, and for intellectual disability. So these were the 3, 4 guidelines which they have given. So in India, age criteria to be eligible for autism disability is 6 years, or 5 years and above. So let's come to the next question. A 9-year-old girl is brought to the clinic for chronic irritability. Her parents report temper outbursts that are difficult to control, extremely frequent, and apparently out of proportion to a particular situation. These symptoms have been present for more than 1 year in three different settings. The appropriate diagnosis is made and various behavioral modification techniques are suggested, including positive punishment. So, which one of the following best describes an example of positive punishment technique? When she stays out for an hour past her curfew, her parents ground her for 2 weeks. When she fights with another student in the class, the teacher gives her frowning face stickers on a progress board. After she fights with a sibling over gets to play the video game, the father takes the video game away from both the children. After a cell phone rings in the middle of the chemistry class, she is ignored by the teacher for not turning the phone off before the class. So what among the following? So just to give you a brief, here is a child who has chronic irritability and has a lot of behavioral issues. And the therapist tried giving him behavioral modification techniques. So they have given a positive punishment technique. So among them, which of the following is an example which describes a positive punishment technique? See, they're basically what it is a positive punishment or positive reinforcer, whatever you can say. I'll just see, these are the examples. What does a reinforcer mean? Reinforcer means whenever you add something to increase the frequency of a desirable behavior. So it can be positive, it can be negative. Positive means you are adding something. Negative means you are removing something to attain a behavior. So reinforcer just means you increase the frequency of desired behavior. It can be a positive reinforcer when you add something to improve the behavior. It can be a negative reinforcer when you remove something. Similarly, is for the punishment. Ultimately, positive reinforcer results in positive punishment. That is, you are adding something. Your punishment means you are giving a consequence. So, when you are adding something to give the punishment, it is known as a positive punishment. When you are removing something to give the punishment, it is known as a negative punishment. For example, the child is doing a lot of mischief in the class and the teacher throws him out of the class. So it is a negative punishment because you have removed him. Whereas if a child who is doing a lot of mischief in the class, the teacher gives him a slap or XYZ. So it is a positive punishment. The teacher has added something to the child. So taking to this background, what would be your option among these four things? We need to identify there is a difference between punishment and reinforcer. Yes. So probably now you are able to understand the concept. The answer here is B, because the teacher gives the frowning stickers on a progress. In all the other options, it has been a negative punishment, except D. D is something which is considered to be an attention-seeking behavior, so it has been ignored. Whereas rest of the other two options, A and C, are negative punishment because they have been taken off of doing a mischief or negative behavior. So the correct option here is B, because here something is added to give a punishment. So the teacher gives him a frown and stickers on his progress. So there is a difference between reinforcer and a punishment, but punishments, again, both reinforcers and punishments can be a positive and negative. Punishment is basically more of a consequence. So when you give a something, add to it to cause a consequence, it is positive. When you remove something to cause a consequence, it is negative, punishment. So answer here is B. Uh, we have discussed this. Let's come to the other question. Now, 4-year-old male child with moderate autism spectrum disorder comes to the clinician with mother. The mother complained that he sleeps very late in night. It sometimes takes 2 hours to 3 hours to make him sleep. Now his usual time of sleeping is around 1 a.m. and sometimes he wakes up early in the morning, but usually sleeps around 8 to 9 a.m. As a result, his mother health is also deteriorating. She also gives history of frequent constipation and sometimes bloating to the child. The mother feels his immunity is low as he has history of frequent bouts of seasonal cough and cold. The child has also a habit of taking frequent daytime naps before going to therapies in evening. The mother also tells that he is on casein-free diet. What is the most appropriate first step in approaching to the child's sleep problems? Excess soft tissue to rule out adenoids. Initiate melatonin low dose as it is the safest hormonal therapy for sleep issues in autism. Ask parents to prepare a 24-hour diary sleep pattern for the child. X-ray rect abdomen to check for ficolates and start impaction dose of PEG followed by maintenance. EG to rule out circular silent seizures. See, if you go on all these options, probably all of the options are correct. But the question is, what is the most appropriate first step in approaching to the child's sleep problems? Okay. So initially, before giving you an option, I'll just revise you what are the guidelines in managing sleep issues in autism as per NICE. Okay. So as per the NICE guideline, the first and foremost step in managing sleep issues is taking a detailed sleep history from parents related to triggers, frequency, duration, daytime, and bedtime issues. The history is commonly evaluated using BEARS tool. BEAR tools means bedtime problems, excessive daytime sleeps, waking during night. R is regularity and duration of the sleep, and S is snoring. So these are the parent related, where they will the age categories. So and accordingly, associated problems like adenoid gut issues are common comorbidities which needs to be evaluated and managed accordingly. Pharmacological approach is generally kept as last resort after initial approaches fails to bring about improvement. So BEAR screening tool is for sleep issues in autism, which gives you all this. So any child becomes you the sleep issues problem in autism, the first and foremost guideline as per the NICE is to manage the sleep issues. How? So you need to take a detailed sleep history from the parents. So the answer would be taking the parents to prepare a detailed dietary 24-hour sleep pattern of the child using Bayes tool, which looks into consideration the bedtime problem, excessive daytime sleep, awakening during regularity and snoring. Now in this child, probably we might start on a melatonin at first go. But the foremost thing we forget here is the child is taking a lot of daytime nap. So the first and foremost, you need to check it. What is his duration of total sleep? So you need to cut down his daytime nap. You need to cut down daytime nap, moderate his sleep pattern. What is his sleep and circadian rhythm or sleep? And then accordingly, you need to monitor and manage the associated problems. Probably his sleep issues might get cut down if you are able to explain the parents and take a detailed dietary history, detailed sleep history in this. But the best option here, the first initial approach, rational approach in this child would be taking a detailed sleep history of the child 24-hour using Bayes tool. And then accordingly, you need to manage the problems. But all the options seems to be correct. But the right option here is the first approach would be taking a detailed dietary history regarding the sleep pattern. So another question is 17-month-old child accompanied by parents. Their concerns are he has not started speaking words, just say maba sometimes. No speech on demand. 17-month-old child, no speech on demand, just say mama, baba. He has an elder sister, enjoys cuddling, pretend play, and can identify family members. So it's a good positive sign that 17-month-old child is doing cuddling, plays, pretend play, and can identify family members. Both parents are working, hence child remains with grandparents. Parents admit that his screen time is around 7 to 8 hours per day. He started walking at the age of 11 months. Mother says he can express his needs by gestures and pointing toward things of his interest. But he shows tantrums a lot, especially with father when his demands are not met. So the first initial approach in this child would be reduce zero screen time and reassess after 3 months, do ESA and CAST to rule out autism, refer to SLP and start speech therapy, indulge him in small peer groups. So what would be the initial first step? Again, here the option is what is the initial first step in managing this child? Though all seems to be right, but what is the first initial step? Yes, absolutely. So here we need to reduce the zero screen time and then reassess, because most of the things where he is giving you no speech on demand, that is socialization issues. This could be an example of virtual autism. Around last 2 to 3 days back only, I gave a talk on virtual autism, and that is a typical example that where we discussed about how to need to differentiate virtual autism from a true autism. And just to make understand that in virtual autism, we will get all features of socialization difficulty, hyperactivity, isolation, not listening and responding to commands. But the typical core features of true autism, like repetitive stereotypic movements, behavioral issues, and no pointing, all those things, typical core features, uh, no pointing, gestural, non pointing, verbal hand lending. So, those repetitive stereotypic movements, they will be sensory issues. They will be typically present in a child on autism, but they will not be present in a child on virtual autism. And once you remove the screen, probably those symptoms wane off. So, it is more of related to a socialization and language, whereas in case of true autism, it is along with social and language, it is more of a sensory. Whereas in a virtual autism, sensory part is not there. It is missing. It is only the social and the language part. And once you, because the child has been isolated from the language and the social part because of the excess use of screen. And another theory which they state that why that, and as per the guidelines, virtual autism typically happens in the age group of 0 to 3. And the term virtual autism was coined in the year 2021. And it was coined by a person who was a Romanian psychologist. And he was very fascinated during that COVID era when he found that the children between the age of 0 to 3 years are given excess screen time. That is, there is also a clear guideline for the definition of virtual autism. Screen time of more than 3 hours in 24 hours in a child between 0 to 3 years gives pictures of virtual autism, which gives you characterized by hyperactivity, delayed language and socialization skills, and isolation. There is no such word which has been used in terms of sensory issues, whereas in terms of true, it will be sensory. So it is more of a picture of virtual autism. And so here the correct option would be reduce screen time and reassess after 3 months. So, which of the following is not an early or red flag sign of autism? Again, it is something confusing. No babbling by 10 months, no meaningful two words by 24 months, repeat odd movements or actions, lack of facial expression by 6 months. Which we always talk about early or red flag signs of autism. Which of the following is not a red flag sign? Okay, so most of them have you answered C. The answer C is not the correct option. It is A. No babbling by 12 months. Now, these are, now I cannot make any change in that. These are the target milestones which clearly define you the red flag signs. If there is no babbling by 12 months, that means it is clear cut red flag signs for autism. There is no such rule of 10, 12, 14. It is clear cut 12 months. It is clear cut two word phrases by 24 months. It is more of a theoretical rather than practical. But these are some of the red flag signs which has been documented in the text. Repeat odd movements or actions, it is basically they want to tell it as a repetitive stereotypic movements, which they have defined it in a layman term to make it more simpler towards identifying red flag signs. Because nowadays we are more of a teacher parent training, school training programs. We give awareness program for autism. So where we explain about red flag signs. So they have given the red flag signs more of a normal language term so that it becomes more expressive and understandable even for the layman. So repeat odd movements or action basically means repetitive stereotypical. Lack of facial expression by 6 months, we have discussed earlier also, which is reciprocal imitation, which was initially not there and has been added in the latest Nelson and even the latest guidelines of DSM-5 for early red flag signs. So no babbling by 12 months is the correct option rather than by 10 months. Rest all the other options are correct. So the answer here is A, no babbling by 10 months. It should be no babbling by 12 months. So I think we'll cover up the last question, although there are some more questions left, but the time is not there, so we'll cover up with the last question here. The 7-year-old boy is brought by his parents for routine checkup at the clinic. The child is in the normal state of health, but is reluctant in answering the questions about his health. He seems to be dwelling in thoughts and looking tired. His parents complain that he has been underachieving in his school academically and is known to have fewer friends. His reading and writing is below compared to his age. He is amicable at home and is normally interactive with his parents at home, but there are instances where he loses attention and cannot cope up with the pace of conversation. Which of the following is the most likely diagnosis? Oppositional different disorder, attention deficit, autism, or dyslexia? So he is a 7-year-old child, came for the routine checkup, and he is very much reluctant in answering questions about his health. And he seems to be lost in his thoughts, and his school performance is poor, and he's amicable, but he's good interactive with his parents at home. But there are some instances where he lose attention, cannot pace up with the communication. So, what is the most likely diagnosis in this child? So, all these questions have been they have not been taken from any text. Probably they have been prepared by me only. So if you feel any of the options is not correct, or if you want to have a discussion on particular question, you feel that that could be not the right option, then we can have a discussion on that. Okay. See, first of all, oppositional different disorder clearly does not fulfill the criteria of DSM-5 for oppositional different disorder in this child, because it has to be at least up to 6 months, and there are certain things which clearly define oppositional different disorder, which doesn't clearly fit into this. Then attention deficit. Now, attention deficit disorder uh, clearly defined as per DSM-5 that the features of attention and hyperactivity should be present in two or more sittings. So, do you feel that this child fulfills the criteria of ADHD? Yes or no? If yes, how? How does he fulfill the criteria for ADHD in this child? Because for ADHD, the features of hyperactive and hyperactivity and inattention should be present in two or more settings. And there are no such features which indicate that the child is hyperactive or inattentive in the school or in the scenario at home. Then autism spectrum disorder. Do you feel any features which are suggestive? Though there are some things which we feel that he's seen to be lost in thoughts and looking tired, underachieving. But here are some things which has been given. First of all, regarding dyslexia, the age group of 7 years, which fits into the criteria for dyslexia, because generally we diagnose at the age of around 5 years and plus when the child is in the school age. Secondly, the most important thing is reading and writing is below compared to his age. Specifically, they have clearly mentioned the reading and writing is below compared to the age. And as per the IDA, International Dyslexia Association, and as per DSM-5, which clearly mentions dyslexia is a neurodevelopmental disorder where the child's reading and writing is below compared to his age. Though his IQ and intellectual IQ is at par with his age, but his reading and writing will be below as compared to his age, which will indirectly affect his learning and speaking and communication. Because the most hallmark of children on dyslexia is that they have a poor phonological awareness and processing. Because of the poor phonological awareness and processing, they have difficulties in reading, difficulties in sight words and reading letters such as cat, mat. They might read as bat, pad. Not a 7-year-old child, but depending upon the age of the child. So the correct option here is the child fits up more into the criteria of dyslexia rather than any of the above things. I hope I hope you are satisfied with my explanation for this question. So the option for this correct option would be dyslexia in this child. There are okay. Let's come to this question. A painting competition has been organized by school for special needs children. The theme of the painting is Independence Day. So there is a competition being organized by school for special needs children, and the theme of the painting is Independence Day. And around 10 children participated in the competition. A huge painting of national flag was provided to the children, and all the 10 children were asked to color the specific areas of the flag. And a common pool area of colors, drawing sheets, and pencils and other stationery material was provided from where children can pick up and color the designated areas of flag, because all of the 10 children were given the designated areas of flag to color, but there was a common pool area from where they can take their colors, drawing sheets, pencils, and other. And hence, an environment was given to the children where they can work on the individual projects with sharing materials and conversation. So, what type of play is being demonstrated in this? Parallel play, cooperative play, solitary play, or associative play? Okay, now these are called the Parton stages of stage. Now there are approximately six stages of play. Parton has given six stages of play. Now here the correct option is it is more of a cooperative play. It is not an associative play. It is a cooperative play. Now, there is a difference between two cooperative and associative play. Now, cooperative play means where the child are involving with each other, where they are doing some collective work and the task and collective work to achieve a common target. So here all the children, 10 children, are doing a collective work to achieve a common target, whereas an associative play is where the target is common, but all the children are targeting towards a common area with differences. For example, suppose there is a flower and there are four children who are completing this painting of flower. One child is providing you the colors, one child is doing the painting, one child is rubbing. That will be giving more of an associative play because they are doing individual tasks to complete. Whereas cooperative play is where all the children are involved in a common task to complete one activity. So here they are all involved cooperatively. One is doing the coloring sheets, other is doing a painting sheets, they are doing the pencils, but the task is common and they are fulfilling different areas. So it is more of a cooperative play where they are involving in individual projects. In associative play, there is no individual project. They have all the children will have to fill that common target area. The coloring should be in that common. Here the children have been given separate targets of flag to color. So they have an individual projects. Whereas in associative play, there will not be an individual project. It will be an common project for all the 10 children. And all the 10 children will be involved in that project. One will be giving the pencil, one will be coloring, one will be rubbing. Whereas in cooperative play, they will have all individual projects. So that is the difference between the two. So the answer here is cooperative play. So I think I will complete with this presentation today because I have more questions, but the time doesn't permit. So let's finish it off here only. So I hope we had some useful discussion on today's topic. So if anyone has any doubts in these questions, what we have discussed, we can discuss on the our WhatsApp group. And for the timing, then I will close up the session and we'll be taking up the session on music intervention next week by Dr. Neha. That will be the last session in our webinar presentation series. So thank you everyone for joining this today. I hope it was an interactive, try to make it an interactive session for everybody and including me also. So thank you. Good evening. Have a great day. Thank you.